أو كان ضيق. وإن شاء الله الآن يعني نطمن أنكم برضو تدعون باقي الزملاء للأكتيفيتي اللي للمرة الثانية إن شاء الله راح نستمر فيها إن شاء الله. وممكن بعد هذه نتأكد هل الوقت مناسب لكم أو لا، أو نغير الوقت زي ما قال بعض الزملاء. لكن نرحب فيكم، وشكر جميل ورائع لدكتور عبد الله على مشاركته في المحاضرة، وهي إن شاء الله بتكون بعد كذا انتراكتيف والأسئلة مفتوحة لكم. حفاظا على وقتكم، وأعرف أن عندكم أشياء أخرى كثيرة. go back to you دكتور عبد الله تبدأ. شكرا لكم.
السلام عليكم جميعا. شكرا دكتور عبد العزيز على الانترودكشن، وشكرا للزملاء على حضورهم ووقتهم في هذه المحاضرة. طبعا أنا راح أتكلم عن some of the pathologies that can cause acute abdominal pain and imaging findings. هتكون ultrasound و CT و MRI. I'll try to simplify it for non-radiologists to understand some of the imaging findings that we find and how can they help us in narrowing the differential diagnosis and imaging. So there are, as you know, there are many causes of abdominal pain. This is just to list a few of them or some of them. We will not have time to go through of them. I'll give it 25 minutes. Then we'll give a presentation. Then at the last 5 minutes, we can leave it for discussion. We'll go through as many of these as we can. We can continue the rest of the case, the rest of the topics later on. So the first thing is acute cholecystitis. We all know how stones look on ultrasound. This is a gallbladder stone. You can see the gallbladder contains fluid. That's why it appears black. We call this echolucent or anechoic on ultrasound. And the stone is usually echogenic with posterior shadowing because the sound waves cannot pass through the stone. This is a sagittal image or longitudinal image of the common bile duct, the CBD, and you can see there's an echogenic structure in the lower CBD, and there's a very thin shadowing posterior to it. So not all shadowing is very clear as this large stone. Smaller stones can cause small shadowing, which can be very difficult to detect. So it needs, as you know, ultrasound is operator dependent. It depends on the skills of the sonographer and whoever is scanning. But it is the most sensitive modality for gallbladder stones. And it's widely available. It can be done by bedside. It's quite inexpensive and is very good for evaluating the gallbladder. So not all stones are small like this one. Some of them, they can be large. You can see here, there's the gallbladder. Almost the entire lumen of the gallbladder is filled by the stone. The stone is this extending from the fundus to the body. Here's the fundus of the gallbladder to the neck of the gallbladder. And there's a large stone occupying almost the entire lumen of the gallbladder. So what do we see in acute cholecystitis? There are some imaging features you can see on the images and some you cannot see on the images. For example, the imaging features that you find in the images is the stone, which is usually impacted in the neck of the gallbladder. You can see an echogenic structure with shadowing. You can see the thickening in the gallbladder wall. The thickness of the gallbladder should not exceed 3 millimeters. You can see clearly the thickness here. If you compare it to the previous image, you can see very nicely there's no thickening of the gallbladder. Well, in this case, there's very clear thickening of the gallbladder wall. And most importantly is the tenderness. We call this sonographic Murphy sign. This is very important to see whether this thickening is due to acute cholecystitis or due to other causes. The thickening in the gallbladder wall has a very long list of differentials. Some of them include neoplasms, infection, hepatitis, hepatic congestion, reactive thickening due to adjacent infection or inflammation such as pancreatitis or pyelonephritis or diverticulitis. If the patient has a third spacing, they can have also edema in the gallbladder wall. So not every stone and gallbladder wall thickening is diagnostic for acute cholecystitis. Most importantly, the radiologist and whoever is scanning the patient should see if the maximum tenderness is over the gallbladder area. We've seen sometimes confusing cases, patient coming with acute hepatitis or acute hepatic congestion or acute pancreatitis. If you put the probe in the right upper quadrant, they will have tenderness. But the sonographic Murphy sign should be tenderness specifically over the gallbladder, not over the right upper quadrant. So if we don't find that, it's very difficult to confirm the diagnosis of cholecystitis. Sometimes the patient is on painkillers and the tenderness cannot be assessed properly. Sometimes the patient is ICU patient, unconscious, and they can have fluid overload. They can have thickening of the gallbladder wall, and they might have incidental stones, and they have a distended gallbladder due to prolonged fasting. And you don't know, is this acute cholecystitis or just incidental thickening? So the way to go through this, if you cannot elicit the tenderness over the gallbladder, you can always go for a HIDA scan to assess acute cholecystitis. Now, some of the complications of acute cholecystitis include perforation, gangrene, and perforation. You can clearly see here if you look at the right lower corner, here's the lumen of the gallbladder. You can see stone within it causing shadowing. And adjacent to the gallbladder, you see a collection. If you assess this collection further in the right lower corner here, you can see here's the lumen of the gallbladder, the lumen of the collection, the membrane separating them, and you can see there's a defect. There's communication between the two lumens. So this is perforation of the gallbladder. Another case of perforation of the gallbladder, you can see two lumens, the lumen of the gallbladder, the lumen of the collection, and the communication between them. This is one of the complications of acute cholecystitis. Can be diagnosed by ultrasound. You don't need a CT for this, but sometimes some people are not very sure about it, and they can do a CT. You can see the CT shows this is the coronal image, shows two teardrop-like structures, one of them having, or both of them having stones. It looks like a duplicated gallbladder, while this is actually just a large descended gallbladder with multiple stones and a large collection adjacent to it. Here's the gallbladder and the collection adjacent to it. Okay, so another case of perforation, you can see on the CT scan, the lumen of the gallbladder, and you can see the defect in the wall and the collection adjacent to it due to perforation. One of the complications of acute cholecystitis is emphysematous cholecystitis. Here's an X-ray. You can see very clearly pear-shaped gas-containing structure, the gas in the wall and gas in the lumen of the gallbladder, indicating emphysematous cholecystitis. As you know, this usually happens in immunocompromised patients, and it is usually a very severe infection. If you see gas just in the lumen without gas in the wall of the gallbladder, this could be as a part of pneumobilia, which can be seen after ERCP or when there's fistula with the duodenum. So not every gas in the lumen of the gallbladder is emphysematous cholecystitis. You need to have gas in the wall as well to call it emphysematous cholecystitis. Stones can have different morphologies on CT scan. They can have soft tissue density. They can have peripheral calcification. They can have onion peel appearance or rings of calcification, or they can be completely calcified. So sometimes they can be fluid density and not detectable. So CT is not very sensitive to detect stones. 20% of gallbladder stones are radiolucent on CT and cannot be seen on CT scan. The most sensitive modality to look for gallstones is ultrasounds, much better than CT to detect gallstones. If you cannot do an ultrasound, maybe an MRCP is also very sensitive. Now, sometimes gallbladder stones, they can be very tiny and adjacent to each other, and they can be layering stones like these. These are multiple tiny layering stones. They look like milk of calcium, but these are actually very tiny stones. After cholecystectomy, sometimes you can see some complications like abscess formation after cholecystectomy, or sometimes you can have bleeding. And this mottled structure within the lumen of the gallbladder after cholecystectomy is Surgicel, which, as you know, is hemostatic agent and can look like mottled gas, sometimes mistaken as abscess or fecal matter because of the mottled appearance. We need to know, so we need the clinicians to tell us if they use Surgicel or any hemostatic agents during the procedure, so not to confuse the picture between normal postoperative findings versus abscess. This was called initially as an abscess because of the presence of collection with gas, but when we dug in the history, we found that the surgeons used hemostatic agent at the gallbladder fossa to control some bleeding, and sometimes that can lead to this appearance, which is mottled gas or feces-like appearance. One of the causes of right upper quadrant pain is also liver abscess. Liver abscess Morphology depends on the age of the abscess. Initially, the abscesses start as regional cholangiohepatitis, which is regional inflammation without any liquefaction. Then it can have mass-like structure before liquefaction. Then as it develops, you can see these tiny small locules or cluster of small locules adjacent to each other, and with time they can fuse together and form a larger cystic component. And if you give it more time, it can look like a simple smooth walled cyst. So the imaging of a liver abscess or any abscess in the body depends on the age of the abscess. Initially it can look like solid. ممكن الله يعافيكم نشغل المايك يطفيه. Please turn off your mics, please. Okay, so back to so liver abscess start usually as solid-like appearance, and then they can have small liquefied locules that can coalesce together with time, and they can form a larger cavity. Initially, in the initial stages of liver abscess, it can be confused with masses like metastasis or cholangiocarcinoma because they look solid. Like in this case, you can see there are this is a mass-like lesion with multiple cystic components and solid component. This initially was called as suspicious for metastasis, but when we did further imaging and when we dug in the history of the patient, this turned out to be an abscess. The needle drainage was done and pus came out. Sometimes abscess can be diagnosed by ultrasound. If you see a liver lesion containing gas, that's usually very diagnostic of an abscess. Is an ultrasound of a liver of a patient. You can see there's this necrotic mass in the right hepatic lobe, and you can see these echogenic foci. These echogenic foci sometimes they can be interpreted as tiny foci of gas or areas of calcification. But with experience, you tend to be able to differentiate between gas and calcification. They have slight differences in their appearance. So this was very suggestive of an abscess. We did a CT scan. We can see this tiny black dot here, which was, you don't see a gas in a liver lesion unless it's an abscess. Of course, if there was intervention or there's fistula with the bowel or the skin, you can have gas. But if there is no intervention and there's no fistula with the adjacent organs, the only explanation for these gas bubbles is abscess. Unfortunately, this is not a common finding. It's seen in only 10 to 20% of liver abscesses. But if you see it, it's very specific for a liver abscess. You can say comfortably, this is not a necrotic mass, this is a liver abscess. That's another patient with the right upper quadrant pain. You can see there's a heterogeneous mass in the right hepatic lobe with areas of necrosis. You can see this hypoechoic areas, and it has irregular wall. This was evaluated with CT scan, and you can see CT scan showed this black material, which is gas. There was no history of a recent intervention, and there was no obvious fistula with the bowel or skin. So this was diagnosed as a liver abscess. It turned out to be an infected hydatid cyst. Nonetheless, it was managed as an abscess, infected hydatid cyst. Sometimes abscesses might be very small. We call them microabscesses. Microabscesses, they can be due to pyogenic or bacterial cause, or can be due to fungal, especially in immunocompromised patients. This is a patient with leukemia. If you look carefully, this is an MRI. These are T2 weighted images and T1 weighted images after contrast. You can see very carefully these tiny dots with ring enhancement, tiny dots with ring enhancement in the liver. And if you look carefully, also there are small lesions in the spleen. So whenever you see this morphology in the liver and spleen, a patient who is immunocompromised, this is quite specific for fungal infection, most commonly due to Candida or Aspergillus, but most commonly Candida albicans. So multiple microabscesses in the liver and spleen consider the possibility of fungal infection, especially in immunocompromised patient. A patient came with right upper quadrant pain and abdominal distension. Imaging shows the liver is enlarged. Let me go back to the previous image. You can see this in the MRI. You can see the hepatic veins enhancing clearly. Here's the middle hepatic vein, left hepatic vein, and right hepatic vein. They are enhancing very nicely. If you go to this image, at the area of the hepatic veins, you can see this tubular hypodense structure. tubular hypodense structure, which represents thrombosed vein. So, and you can see the enhancement of the liver, instead of being homogeneous, like in this case, you can see homogeneous enhancement of the liver. The liver is actually quite heterogeneous in enhancement. This usually indicates congestion or inflammation of the liver. So thrombosed hepatic veins, congested heterogeneous liver, and you can see there's also ascites in the upper abdomen. This was diagnosed as Budd-Chiari syndrome. This can also be diagnosed by ultrasound and can be assessed also by CT scan or MRI. Okay, another case of Budd-Chiari as well. So we'll go. Sorry, yeah, this is not the case of Budd-Chiari. I apologize. Here in this case, the hepatic veins were patent. You can see the IVC here and the left hepatic vein, right hepatic, middle hepatic vein, and right hepatic vein. But you can see that the liver is heterogeneous, very similar to the heterogeneous liver on this image. Okay, but what's the cause? This patient has cardiomegaly, and you can see the cardiac device as well. So congestion due to cardiac disease can give you imaging features similar to Budd-Chiari, and in the long term can lead to cirrhosis, cardiac cirrhosis. How do you differentiate Budd-Chiari from congestion? We look at the hepatic veins. If the hepatic veins are thrombosed, it's Budd-Chiari. If they are dilated and congested on the CT scan, then it's congestion due to cardiac disease. Okay. Let's go through this one. So yeah, this was a patient that had recent cesarean section and with history of eclampsia. After cesarean section, she had right upper quadrant pain. We did an ultrasound. We saw this large perihepatic collection. You can see this is the outline of the liver, and there's this collection around the liver compressing it. This was actually subcapsular because it had mass effect on the liver. So it's a subcapsular hepatic collection. So in a patient with preeclampsia, sometimes they can have thrombocytopenia and they are prone for bleeding, which is known as HELP syndrome. High liver enzymes, low platelets in patients with preeclampsia. This is a CT scan showing this collection, which is high density. This turned out to be subcapsular hematoma, and you can see the signs of recent cesarean section. Here's a sagittal image of the pelvis. You can see the uterus is still bulky, and the surgical clips can be seen in the anterior abdominal wall due to recent cesarean section. This is, let's go, okay. So this is another patient that came with right upper quadrant pain and dysuria. The patient did not respond well to antibiotics, so they decided to pursue further imaging. Usually patients with urinary tract infection, imaging is not recommended for all patients, only patients who have refractory or non-responsive to regular treatment, or patients with very severe symptoms or suspected upper urinary tract infection sometimes can benefit from imaging. Patients with recurrent urinary tract infections also may benefit from imaging. So this is a patient who had very severe symptoms and unresponsive to medication. We did a CT scan. This is the coronal images. You can see the normal outline and enhancement of the left kidney. While if you look at the right kidney, you can see this area of low attenuation in the cortex near the upper pole region. It does not have any mass effect, so you can see the outline of the kidney is very smooth. So it doesn't have any mass effect. So we cannot call it a neoplastic lesion. And with history of dysuria and fever and flank pain, you can comfortably say this is most likely focal pyelonephritis. Another patient with pyelonephritis, you can see the striated enhancement, looks like lines. Striated enhancement is another, it's more diffused rather than this focal pyelonephritis. And the rest of the kidney looks normal, while in this case, most of the kidney shows this ill-defined heterogeneous striated enhancement. This is another finding in urinary tract infection. This is another patient who is diabetic with severe signs of urinary tract infection. You can see the right kidney here shows normal density, while on the left side you can see gas density within the renal parenchyma and the urinary collecting system extending to the perinephric space. This is a classic case of emphysematous pyelonephritis. Some people say they might mistake that any gas in the urinary collecting system and the renal pelvis or ureter, you may call it emphysematous pyelonephritis. The gas should be more in the parenchyma, not in the urinary collecting system. Like in this case, you can see it in the parenchyma of the kidney. So this is the case of emphysematous pyelonephritis. This is a critical finding that you need to convey to the clinician immediately so they can take appropriate action. So this is another case with, you can see there is Foley catheter in the urinary bladder with gas in the urinary bladder. Here's the pelvis, left femoral head, right femoral head, and this is the wall of the urinary bladder. It's quite thick. This patient had neurogenic bladder with a Foley catheter and gas in the urinary bladder. If you look up in the upper images, here's the left kidney, and here's the right kidney. You can see some gas bubbles in the right kidney, but they are not in the parenchyma. They are in the urinary collecting system. So this was gas that was refluxed from the urinary bladder through the Foley catheter into the right ureter and into the right kidney. So this was initially called falsely as emphysematous pyelonephritis. It was not. It was just gas in the urinary collecting system, which was refluxed from the urinary bladder into the right ureter and the right urinary collecting system, or right renal pelvis. So not every gas in the kidney is emphysematous pyelonephritis. One of the complications of urinary tract infection is also abscess formation. If you look in the left kidney, there's this cystic mass with surrounding severe fat stranding. Look at the fat around the right kidney. It looks very clean and very dark. The fat around the left kidney looks high density with lines and thickening of the peritoneal reflections. In the left kidney, there's a cystic lesion with a defect in the wall. And you can see around the cystic lesion, there's area of edema or low attenuation. It tells us that this cystic lesion is most likely an infected lesion, and this turned out to be an abscess. And the defect indicates perforation into the perinephric space. So this is perforated renal abscess. This is one of the complications of urinary tract infection. Of course, we need to differentiate this from cystic renal cell carcinoma, the presence of significant inflammatory changes around the kidney, the presence of history of urinary tract infection, and the edema around the cystic lesion all help us differentiate between cystic renal cell carcinoma and renal abscess. Okay, these are sagittal and coronal images of the same patient. You can see the abscess in the lower pole region and the defect in the posterior wall due to rupture. This is a child that came also with a multicystic left renal mass, initially called labeled as cystic Wilms tumor, but when we digged in the history of the patient, there was severe fat stranding around it, and there's edema around these cystic changes. When we dug in the patient's history, and we found that there was history of urinary tract infection, the symptoms of infection were masked by the antibiotics and analgesia. So a needle was put into it and turned out to be, pus came out, turned out to be an abscess. Sometimes abscesses can look like tumors, especially as, if you remember, we said that they start as a solid area of inflammation, then they liquefy into small cystic spaces, then they join together to form a large locule. If you catch them before they liquefy, they can be confusing and they can look like solid mass. This was initially diagnosed as Wilms tumor, but due to the presence of significant fat stranding around it and the previous history of urinary tract infection, we suspected renal abscess, and we recommended biopsy. It turned out to be a renal abscess. Okay, so this is another patient with acute left upper quadrant pain. If you look at the right kidney, you can see the normal enhancement and normal outline, but around the left kidney, you can see there's this collection, which is high density. We say it's high density because if you look carefully here, you can see the collection on the pre-contrast. It's higher density compared to the kidney. So high density collections are usually considered as hematomas. You have to suspect hematoma. So we call this as perinephric hematoma. We recommended the contrast enhanced CT scan. This is the contrast enhanced CT scan. And what we saw is this aneurysm. You can see this structure, rounded structure that has the same density as the vessels. Okay. And there's also this lesion around it that contains fat. So this was an angiomyolipoma containing fat with an aneurysm. The vessels in angiomyolipomas are abnormal, and they are prone to develop aneurysms, and these aneurysms can bleed. So this fat density lesion, if you see a lesion in the kidney with fat density, this is diagnostic of an angiomyolipoma. In addition to that, we found this aneurysm and perinephric bleeding. The next step is to call the interventional radiologist or surgeon to help manage this patient. They can be embolized, or otherwise nephrectomy needs to be considered if the bleeding cannot be controlled. Let me take your attention here to the left renal vein. You can see the left renal vein is patent on the left side. Let me see another image if I can show you the left renal vein. Here's the left renal vein. You can see it's patent, enhancing normally. Here's the IVC, left renal vein and IVC. It crosses in front of the aorta and posterior to the superior mesenteric artery.
طب دقيقة بس، بلنا دقيقة واحدة بس. السلام عليكم، دقيقة واحدة بس، في مشكلة؟ ده حتى عندي دقيقة واحدة. نشوفك طبعا. السلام عليكم. استنى يا دكتور. أيوه السلام عليكم. مفيش.
حطيت يشبك من عندي هنا.
لحظة. السلام عليكم. ثواني بس، كان في خلل في النت ورجعنا تاني.
طيب وقفنا وين؟
دقيقة واحدة يا دكتور.
وقفنا عند أي سلايد؟
هي من 60 ثانية بالضبط أو 40 ثانية.
طيب
ماشي. اتفضل دكتور.
So let's go back to the we're talking about the left renal vein.
عشان طلعت.
ادخل مرة ثانية.
ثواني بس خليكم معايا. السلام عليكم. هنستكمل تاني.
طيب so I'm sorry for this technical error. We had issue with the network. طيب connected. طيب
تمام. كان في خلل في النت.
طيب أعذر على خلل، صار النتورك كان فيها مشاكل. طيب let's go back. So we were talking about the left renal vein. You can see the normal left renal vein crossing from the left kidney to the IVC, passing between the aorta and the superior mesenteric artery. You can see the density of the vessels are very similar. But if you go to this case, you can see here's the left renal vein, here's the left kidney, left renal vein, here's the aorta, here's the superior mesenteric artery. Instead of the normal opacification of the renal vein, you can see a dark band within it. This is a case of left renal vein thrombosis. It can be diagnosed by CT or ultrasound. It can be difficult by ultrasound because you can see the left renal vein can be obscured by bowel, and that can limit the assessment of the left renal vein by ultrasound. So CT or MRI are usually more sensitive to renal vein thrombosis. So this is a patient that came with acute abdominal pain as well. Ultrasound was done. Initially, this was called as simple left renal cyst. You can see anechoic structure, rounded, acoustic enhancement behind it. But this is very dangerous. Very dangerous to call a renal cyst without putting Doppler on it. The reason why is sometimes renal artery aneurysm, they can look like a cyst on grayscale ultrasound. So always, if you see a cyst on ultrasound in any area, put a Doppler ultrasound on it to make sure it's not an aneurysm, hepatic artery aneurysm, or renal artery aneurysm. This was a case of renal artery aneurysm. This was initially mislabeled as a renal cyst. So be careful. Renal cysts should be evaluated by ultrasound to be sure they're not an aneurysm. So this is a CT angiogram of the same patient. You can see, if you look at the coronal images in the left lower quadrant here, you can see is a normal enhancement of the right kidney. Left kidney shows less enhancement. It's slightly small in size. You can see the aneurysm here is quite a large aneurysm. These are the 3D images illustrating the relationship between the aneurysm and left renal artery. This is a patient after trauma, had right flank pain. You can see the normal enhancement of the left kidney, while the right kidney has no enhancement at all, only linear enhancement in the capsule. This is a complete infarction of the right kidney due to renal artery dissection. Due to renal artery dissection. Okay. The enhancement of the capsule is seen because the capsule is supplied by small retroperitoneal vessels. So you can see normal enhancement in the capsule. But the renal parenchyma does not enhance due to occlusion of the renal artery. It can happen usually after dissection, especially after trauma or intervention. So renal stones. Renal stones are a common request, and we get in our department, patients with flank pain to allow renal stones. The most sensitive modality, as you all know, to assess renal stones is CT scan. Sensitivity is more than 95% for renal stones. And it's much better than ultrasound, especially for stones less than 4 millimeters. It's much better than ultrasound for ureteric stones. And CT is also superior to ultrasound to assess other causes of flank pain. Not every flank pain is a renal stone, so sometimes it could be pyelonephritis, sometimes it could be hemorrhage, appendicitis, cholecystitis. They can cause also, or pancreatitis. They can cause flank pain, and these can all be assessed by CT scan. So the modality of choice to evaluate renal stones is CT scan. So if you compare here, if you look at the axial images on the right upper side, you can see the right kidney and left kidney. You can see hydronephrosis. The renal pelvis is dilated on the right side. If you compare the fat around the left kidney and the fat around the right kidney, you can see the fat has higher density around the right kidney with areas of lines around it. This is fat stranding, which is seen in infection, congestion of the kidney, or obstruction. If you follow it down, you can see the right ureter is dilated, and there's a large stone in the right mid-ureter. Coronal images, so this large stone, you can see the ureter dilated above it, and it stops at the level of the right mid-ureteric stone. Okay, so CT is sensitive for almost all stones, even uric acid stones, or xanthine stones, or sturvite stones. They are seen on CT scan. So it sees almost all stones, except rarely some indinavir, which is antiretroviral agent used for AIDS, can be radiolucent on CT scan. But these are very rare stones. So indinavir stones, which is a medication used in HIV patients, can be radiolucent on CT scan. Otherwise, all stones are radiopaque. So another cause of upper abdominal pain is pancreatitis. Here's a normal pancreas. We took a long section of the pancreas. You can see the pancreatic tail, pancreatic body, pancreatic neck, and pancreatic head, and the pancreatic duct illustrated very nicely. Not all CTs, of course, are as clear as this one, but this is brought as an example to see what's the normal appearance of the pancreas. As you know, chronic pancreatitis, there's chronic damage to the pancreatic tissue with fibrosis and calcification and ductal stones. So it's very obvious. You can see the calcification in the pancreatic tissue. Here's the pancreatic tail, pancreatic body, and neck. and you can see the areas of calcification due to chronic pancreatitis. In acute pancreatitis, we don't always see imaging findings. In mild interstitial pancreatitis, a CT scan can be very normal. So normal CT scan does not rule out acute pancreatitis. And not all pancreatitis need to be investigated by CT scan. So if it's mild and can be confirmed by clinical findings and high lipase and amylase, and the patient, it's a first attack, young patient, you don't need always to do CT scan. CT scan is done for severe cases, recurrent pancreatitis to rule out complications, or in old patients to rule out masses that can cause acute pancreatitis. So what's the role of imaging? Is to evaluate the presence or absence of pancreatitis, to look for complications of pancreatitis, and also to assess the cause of pancreatitis if visible. So you look for CBD stones, you look for masses, and you look for complications such as collections and necrosis. So if you look here, here's a patient with acute pancreatitis. You can see the pancreas, and around the pancreas there is fat stranding and fluid collection around the pancreas. So this is a case of acute pancreatitis. Another case of acute pancreatitis, you see the pancreatic tissue is replaced by this low attenuation tissue. So there's lack of enhancement in some areas of the pancreas. Instead of seeing the normal enhancing pancreas, you see this hypodense low attenuation tissue. This is necrotizing pancreatitis. So there's necrosis of the pancreas, and you can see, and you can, as you know, necrotizing pancreatitis is associated with higher morbidity and mortality, especially if it's more than 50%. So usually when we report these patients and we mention there is areas of necrosis, we need to tell them the percentage of the necrosis. So I think we finished now more than 25 minutes. We'll open the floor for any questions. So I'll open the chat box for any questions.
You can raise hand, anyone to talk, or write a question in the chat, and Dr. Abdullah will answer it.
I can't see any questions or hear any questions. So I assume we're done with the lecture. We can continue the rest of the topics in a future talk if you want to.
Okay, Doctor. Okay, go on.
Okay. Dr. Muhammad Ramadan, can we conclude? Dr. Msabahi?
تفضل دكتور معك لو باقي سلايد معنا 5 دقائق.
I can't hear you. Maybe my mic is.
أنا معك يا دكتور عوض. هكمل يا دكتور برزنتيشن، مفيش في أسئلة وصلت؟ مفيش. أنا فاتح من عندي.
Okay. So do you have any? We finished half an hour.
Oh.
So I think we should conclude here.
Okay.
Unless there are any more questions, we can continue the rest of the topics later on in the future talk.
شكرا جزيلا دكتور عبد الله، وشكرا لحضراتكم على الحضور. كده هنختم يا دكتور.
طيب شكرا جزيلا.
شكرا دكتور عبد الله، شكرا جزيلا.